Hi, and welcome back to the Pro PA podcast. I'm your host, Angie Urbina, and today we're covering scabies, a common condition that you're likely to encounter in primary care and dermatology. While straightforward to diagnose with classic signs and symptoms, scabies requires a careful approach to treatment and patient education to ensure successful outcomes. Let's dive into what you need to know to confidently manage scabies in your practice. First and foremost, let's talk about the patho. Scabies is caused by the mite Sarcoptes scabiei varhaminis, an 8-legged mite that's too small to see with the naked eye. After mating, female mites burrow into the epidermis and lay eggs. This triggers a delayed type 4 hypersensitivity reaction to the mite feces, and eggs, which is the cause of the relentless itching. The mite burden is generally low, less than 20 mites in usual cases, but in cases of crusted scabies, there can be millions of them. Transmission of scabies usually occurs through direct and prolonged skin-to-skin contact, as may occur among family members or sexual partners. Now, who does scabies affect? Scabies doesn't discriminate. It can affect anyone and anywhere. However, crowded living conditions, such as nursing homes or prisons, increase the risk of outbreaks. Children, people with weakened immune systems, and those in resource-limited areas are particularly vulnerable. The clinical presentation includes intense itching, which is usually worse at night, and classically presents as multiple small erythematous papules, often excoriated due to scratching. Burrows may be visible as thin serpiginous lines and are commonly found in the interdigital web spaces, wrists, palms, soles, the penis, elbows, feet, buttocks, axilla, and groin. The head is usually spared except in very young children. Another note about children is that often they have heavy involvement of the palms and soles and all aspects of the fingers. And one last note is about a special variant called crusted scabies. This presents with thick, scaly plaques and is seen in immunocompromised or neuro-impaired patients. These cases carry a much higher mite burden, as we mentioned a bit ago, and requires a more aggressive treatment. Moving on to the diagnosis. The diagnosis of scabies is confirmed through the detection of the scabies mite, eggs, or fecal pellets, also known as scabala. This is done through microscopic examination. Basically, what is done is you apply mineral oil to the sites where you will take the sample. You want this to be high-yield areas. You obtain the sample through scraping multiple sites of the affected skin and apply to a glass slide, which is then analyzed under the microscope. However, since these findings are not always readily detected given the low number of mites in patients with classic scabies, and microscopic examination is not always feasible, a presumptive diagnosis is sometimes made based upon a consistent history and physical exam. Now, let's talk about the management. First-line treatment for classic scabies includes topical permethrin 5% cream. This should be applied from the neck down and left on for 8 to 14 hours. Now, it's important to remember that it is necessary to reapply this 1 to 2 weeks later to target the newly hatched mites. Now, as we mentioned a bit ago, scalp involvement is common in young children. Therefore, in this population, permethrin should also be applied to the scalp and the face, sparing the eyes and the mouth. In the case of crusted scabies, large scabies outbreaks, or when topical application isn't feasible, an alternative is oral ivermectin. Now, it's important to understand that the patients may still have pruritus for a few weeks after eradication. And for these patients, you may want to give them antihistamines or topical corticosteroids to help manage these symptoms. And one last note on management is that it is crucial to treat all close contacts, even if they're asymptomatic, to prevent reinfestation. On that note, let's talk about some environmental measures that are important in scabies. To minimize recurrence, you will want to educate on washing all clothing, bedding, and towels used within the last 4 days in hot water and dry on high heat. Things that can't be washed should be sealed in a plastic bag for at least 3 to 5 days. A complication you will want to watch for is a secondary bacterial infection, such as impetigo, which can occur due to the scratching from the intense itching. Lastly, before testing ourselves with some questions, here are some clinical pearls. Number 1. Scabies should be high on your differential for a patient with intense pruritus that's worse at night. Number 2. Post-treatment itching doesn't mean treatment failure. It's usually due to the hypersensitivity reaction that can last weeks. And number 3. Patients with crusted scabies need a combination of oral and topical therapy, and they should be isolated to prevent outbreaks. All right, let's get some practice. Question 1. A 35-year-old woman with no previous medical history presents with intense itching that worsens at night. On examination, you observe multiple erythematous papules and thin serpiginous lines between the fingers and on the wrists. She recently stayed at a homeless shelter. Which of the following is the best treatment of choice? Is it A, oral ivermectin, B, topical permethrin 5% cream, C, topical hydrocortisone cream for symptomatic relief, or D, observation and reassurance? I'll give you a couple of seconds. If you chose B, topical permethrin 5% cream, you are correct. This is the first-line treatment for scabies. In this case, it would be applied from the neck down and repeated in 1 to 2 weeks to kill newly hatched mites. Question 2. A 45-year-old woman presents with a 3-week history of intense itching worse at night. On examination, you observe erythematous papules on her wrists and burrows in the interdigital spaces of her hands. You suspect scabies but want to confirm the diagnosis. What is the best diagnostic test to confirm scabies? Is it A, fungal culture, B, KOH preparation, C, skin scraping with microscopy, or D, dermoscopy? If you chose C, skin scraping with microscopy, you are correct. This is the best diagnostic test to confirm scabies, as it allows for identification of mites, eggs, or fecal pellets from the skin lesions. Great job! As always, thank you for tuning in to this episode of the Pro PA podcast. Scabies is a manageable condition with proper diagnosis and treatment, but patient education is key to preventing recurrence. Don't forget to subscribe and turn on notifications so you never miss an episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.